We move on to the leg of dilemmas in decision making again, and may I invite Dr.Sumita Chowdhury to speak for the next 11 minutes on the tsunami of coronary artery disease engulfing Indian women.
Thank you, and I want to extend my heartfelt thanks to Dr. Chopra for inviting me here, and Dr. Brasher and the other members of the organizing committee. It's a real pleasure and honor to be here, and I think this is the best place to start a healthy heart. So with that, I want to share with you some of the data on women and heart disease, and specifically about the tsunami that we are experiencing here in India. So every minute, a woman dies of heart disease. And these are staggering statistics that not all of us are aware of. And heart disease is indeed the #1 killer of women today. The number of women that die from all types of cancers combined is a small proportion compared to the number that die from heart disease. And yet, women have this misconception that it's indeed the cancer that they need to worry about and not heart disease. If you look at the statistics specifically, and these are stats from the American Heart Association, heart disease results in 1 in 3 deaths. Yes, 1 in 3 deaths is resulting from heart disease, but only 1 in 31 is resulting from breast cancer. So we do have a problem, and I think we need to just do more than just reach the surface of the iceberg here. We need to really dig deep and find out what we can do to change these statistics. So most women think of only screening for breast and genital cancers. They rarely think of a comprehensive cardiac evaluation. One of the biggest myths in our society is that women are unlikely to die from a heart attack. And this has infiltrated the fabric of our culture, our media, and we are familiar with the Bollywood themes of the image of the male actor clenching his chest and falling to the ground with a heart attack. And you never see a woman depicted in that role. And the truth is that it's more women that die of heart disease. In fact, these are again stats from American Heart Association. Since 1984, more women have died each year from heart disease than have men. And an estimated 43 million women suffer from this disease in the US. And so it's the women who's going to not have such melodrama. They're going to present with more subtle symptoms and not clench their chest and fall to the ground, but actually suffer silently. And this is what the problem is, that we don't recognize this type of presentation in women. Recently, a survey was done in India involving over 500 cardiologists, and most of whom have found that in their practice, the prevalence of heart disease that they're seeing has increased in women by 20%. And these women are having heart attacks, but rarely do they have a smoking history or alcohol drinking history or even a family history. Their risk factors have a different tendency, and we really need to understand this if we want to make a difference. So women in India, they're having a different presentation, a different risk factor profile. So let's go through some of these and see what we can do about them. We heard yesterday about the obesity epidemic, not just in other parts of the world, but right here at home in India. We have obesity and metabolic syndrome, which is resulting in elevated levels of triglycerides, low HDL, insulin resistance. And indeed, the International Diabetic Federation has now suggested that we should have a lower cutoff for the abdominal fat of only 80 centimeters in women. We also have the risk factor of atherogenic dyslipidemia. In fact, Dr. Inas has done some pioneer work in demonstrating that the Indian woman has a lower functional HDL. So that's a lower level of a large HDL particle. And also their total cholesterol to HDL ratios are abnormal. They have very high levels. We also find a poor diet and lack of physical activity as being a significant risk factor for women in India. Diabetes levels are going up, and this confers a very high risk for heart disease in women, and this is also being seen in younger women. So we are having heart disease in younger women in India than we have in the United States. Hypertension, and then last but not least, the stress level for women in India is tremendous. And we heard yesterday about the mind-body connection. I think this is really valuable, and we really need to emphasize this in India. So many of you are familiar with the atherosclerosis timeline, and I will emphasize that there is no gender bias. Women have this same atherosclerosis timeline, which often we fail to recognize. What we have found, and what Dr. Inas and others have suggested, is that women have this atherogenic dyslipidemia. And by this I mean they have a very atherogenic HDL profile, which is the small dense HDL. They have increase in small dense LDL particles. And all this results from the increased triglycerides and the insulin resistance that they are experiencing because of the metabolic syndrome, the diabetes, the obesity that is prevalent in the women here in India. I want to share with you a typical case and see what you think about this. We have an Indian woman, 45 years of age, type 2 diabetes, hyperlipidemia, on treatment with metformin and atorvastatin, has a good diet and exercise program. After 3 to 6 months, you find an A1C of 6.9 and a waist circumference of 110. We already learned from the IDF that this is considered obese, according to the IDF. It's more than 90 centimeters. So how would you treat this case? Would you do anything different? Is there an increased risk that we need to worry about? Well, let's look further. The total cholesterol is 210, LDL of 130, triglycerides of 250, HDL of 30, non-HDL of 180. Most physicians will look at this, and I've seen this in my experience in the US treating Indian patients, that they have been told by many physicians that their cholesterol is fine, their levels are normal. But if you look deeper into this profile, you will see that it's not just the normal, quote, normal LDL level of 130, but you have to look further at the non-HDL. The non-HDL portends a story that is much more valuable often than just the LDL. And if you look in this case, you would see that although the LDL of these two patients are similar, 130 in the first case and 130 in the patient in the second case, but you will see that they have completely different risk profiles. And you notice that the second case has many more ApoB particles, which are considered to be atherogenic, and they are attached to each of the atherogenic particle, which is the small dense LDL particle. So indeed, we do have to look further than the LDL when we treat women. We have to look at their non-HDLs, and also we should look at their small dense LDL particles. I think in India it's fair to say that if we just look at their lipid profile and calculate their non-HDL, it's a very inexpensive way to stratify risk, and one should do this routinely when we take care of our women patients. I will share with you that the small dense LDL alone can predict the onset of cardiovascular disease, and this has been shown in multiple studies. I'm showing one such study on this slide. Again, the non-HDL cholesterol in a recent meta-analysis has also been documented to be a valuable indicator of increased risk, perhaps more than just the LDL alone. So this is another very good reason why we should look at the non-HDL cholesterol when we treat women. So, in summary, what can we do to protect women from the tsunami of heart disease in India? Well, certainly we would need to increase the awareness of risk factors. And this is not just knowledge of risk factors. We need to provide access to appropriate screening for these risk factors. And we need to provide evidence-based management of risk factors. And just increasing the awareness of risk factors are not enough. We also need to make both women and men aware that their symptoms are going to be different than men. So what we call atypical is actually typical for women. And we must emphasize to women that they should seek help when they experience extreme fatigue, shortness of breath, symptoms of indigestion, breaking out in a cold sweat, or even vomiting, dizziness, or lightheadedness. In the presence of an appropriate risk factor profile, this may actually signify a need for immediate attention. And I think we need to do our job to educate both our colleagues as well as the patients at large. And last but not least, we will need more randomized clinical trials on appropriate strategies for prevention. Indeed, in the US, this has become a major bone of contention. Most of the randomized clinical trials have not included enough women, have not randomized enough women. So we do need to have more data before we can make very concrete guidelines on what to do for women. Thank you for your attention.
Hello, I have a suggestion. In the UK, we have a situation where we have the same thing, where women end up having heart problems, and it's not known to them. However, I suggest that perhaps the woman in India could be, like a program could be set up called Her Heart Health India. And so this could have probably like a special set up where it's in every hospital or in every village, and so that people could then be more aware of what can happen to the woman, and just set it up as a big heart like WCCPCI and HHHI, Her Heart Health India.
I love the idea. I think you and I need to sit down and talk.
Okay. Thank you, Dr. Chowdhury.